Aloha, I am Mark Alexander, Executive Director of the Hawaii Medical Association. Thank you for joining us for today's Conversations at HMA, a program which features discussions with physicians and other thought leaders in the healthcare arena. For this edition, we are pleased to have Dr. Geri Young and Dr. Angela Gough, who will present the topic, Healing the Healer, exploring the ulu Lapa, the important need for healthcare professionals to care for themselves and the services ulu Lapa provides to facilitate provider health. Before introducing our guests, I want to review the format for this evening's program. We'll begin first with a presentation by Drs. Young and Gough for about 30 minutes. After the presentation, we'll move to the question and answer part of our program. You are invited to submit questions throughout this program by using Zoom's Q&A function. Please type in your questions, comments, suggestions, ideas throughout, and we will feature as many as possible after the presentation. We'll end this program by 6:30 p.m. As always, we want to hear from you. Please email info@hawaiimedicalassociation.org or contact us via our website, hawaiimedicalassociation.org. It is now my pleasure to introduce our speakers for this evening. Dr. Geri Young is a longtime general pediatrician who has served the Kauai community for her entire professional life. After growing up in Honolulu, she graduated from Pomona College and the John A. Burns School of Medicine. Upon completing her internship and residency in 1981, she has practiced on Hawaii. Dr. Young was tapped for administration beginning in 2007, retiring in July of 2023 as the Hawaii Pacific Health Medical Group Hawaii Medical Director. Dr. Young currently serves on the Hawaii Medical Board. She stepped down as a board member for ulu Lapa to take the helm of the organization as Executive Director in August 2023. Dr. Angela Gough came to ulu Lapa as Medical Director on January 1, 2024. Dr. Gough is an addiction psychiatrist with board certifications in general psychiatry, addiction psychiatry, and addiction medicine. Her career emphasis is in medication-assisted treatment of substance use disorders, using a whole person approach to individualized care. Dr. Gough is the president of the Hawaii Society of Addiction Medicine and is a fellow of the American Society of Addiction Medicine. She is a member of the clinical faculty with the John A. Burns School of Medicine of Psychiatry and is also on staff with the Hawaii Health and Harm Reduction Center. Now we are pleased to welcome both Drs. Young and Gough.
Thank you. Thank you so much. I'm Geri Young, and it's been a real privilege to be invited here to speak tonight to the Hawaii Medical Association. I have been very interested in physician well-being because of my family, actually. It's a personal story, and so I moved to Hawaii in 1981. I was practicing as a general pediatrician. My husband had been practicing there since 1980. He was an ER doctor. And in 1986, 5 years into our marriage, he required treatment for alcoholism. And I have to say, we are both so grateful to our colleagues at back then known as Hawaii Medical Clinic, because they were so supportive of him getting treatment. Now, back then, there was no HMA that we knew of. There was an HMA, but they had a impaired physicians committee, I believe, that was the beginnings of Pu'ulapa'au. But back then, we didn't know about it, and we just had a few friends who gave us advice where to go to the mainland to get treatment. My husband did very, very well after his treatment program, and as I said, we became both very involved in physician well-being. He helped a lot of his colleagues through the years there on Kauai, as well as patients, because it's very small, and he was pretty open about his history. And I became involved more in organized medicine. I was chairman of our well-being committee at Wilcox Hospital for 12 years. So we were just both very interested in trying to help other physicians get treatment if they needed it. So I was sitting on the ulu board from 2012. And then when our executive director became ill suddenly, I took this job on August 1st of 2023. It's just been a real pleasure for me to be working with Dr. Angela Gough, who's our medical director. She was co-medical director with Dr. Chris Bjornson, who had been doing that position for 14 years. And many of you I know have heard of him. Dr. Gough and Dr. Bjornson were co-medical directors for about 3 months, but Dr. Gough has taken over as our medical director, lead person, since January of this past year. So I'm turning this over to Dr.
Thank you. Thank you. So I have a few slides that we can go through just to tell you a little bit about our organization, who we are, and the services that we offer. So we are ulu Lapa, the Hawaii Program for Healthcare Professionals. And our mission is to promote patient safety and care. And we do this by improving the health, well-being, and effectiveness of healthcare professionals. So our history, we have ties to HMA. We were started really as a committee of the HMA back in 1983. And this consisted of just a group of volunteer doctors who assisted to monitor their colleagues who were in need at the time. And then finally in October of 2006, that's when we split from the HMA to become an independent organization to allow more flexibility so that we could provide services not only to physicians, but other healthcare providers, and also to improve confidentiality for our participants. Okay, so these are the services that we offer. We provide advocacy and education, information and consultation. And we also help hospitals and other facilities fulfill the Joint Commission accreditation requirements for a physician wellness committee or plan. So we are an independent 501c3 nonprofit. We don't have any sort of formal relationship with any state medical licensing committee, medical board, medical society. Our board is made up of 12 volunteers. Most of them are physicians. Several specialties are represented. We have surgeon, obstetrician, psychiatrists, internal medicine, and ER docs, pediatricians, and addiction medicine docs. We have 2 nurses on our board, 1 pharmacist, 1 dentist, and an attorney. And there are 3 staff members, the 2 of us here with you tonight, and our administrative coordinator. So we serve pretty much anybody with a healthcare license. So not only physicians, but also PAs, nurses, pharmacists, dentists, psychologists, medical residents and medical students, social workers, and veterinarians. So these are the conditions that we treat. The most common one that we see are substance use disorders. We also can provide monitoring and advocacy for those with mental and physical conditions, including cognitive issues, behavioral health concerns like disruptive behavior or anger management, and boundary violations, like professional or sexual misconduct. We can also assist with stress management and burnout mitigation to prevent somebody from getting to the point where they need our monitoring services. We have 3 types of monitoring agreements that we provide. One is for substance use disorders, the other for medical, including physical, mental health, or cognitive disorders, and then a monitoring agreement for behavioral issues. Our agreements vary from 1 to 5 years or more. Most common length is 5 years. So this is kind of where Hawaii stands right now. We have 12,000 doctors who have Hawaii licenses, but just about 3,000 FTEs, which means we have a physician workforce shortage. We cannot afford to lose any more providers, so ultimately our goal is to get people in recovery and back to work. So our general monitoring requirements vary. It's going to depend on the specific condition, the specific circumstances, but in general, most are going to require abstinence from all potential substances of abuse, random drug testing. We use multiple different tissue types, urine, nails, saliva, and blood. We require 12-step meetings with documentation. And when someone is cleared to go back to work, we require a worksite monitor, somebody that can keep an eye on things where they're working and report back and make sure that things are going well. Our participants are asked to meet with me or our board of directors regularly, and we ask that they allow us to communicate with their treatment providers. Some agreements, depending on the situation, may also require their engagement in mental or psychiatric treatment. So I'll walk through a case, just sort of a typical scenario of how somebody might present to us and how their agreement with us might play out. So let's say we have Dr. A. This is a 43-year-old anesthesiologist referred by his medical executive committee at his hospital for possible drug diversion. She was caught on tape stealing fentanyl for her own use. The pharmacy records show above average utilization in surgical procedures compared to her peers, as well as wastage discrepancies. There's been multiple complaints from staff and peers that she appears to be intoxicated when she's at work, and she has displayed some erratic behavior. An on-site urine drug screen was positive for opioids. So she initially denied these allegations, but ultimately agreed to meet with me as a condition of maintaining her hospital privileges. So I met with her for this presumed substance use disorder, kind of heard her side of it and heard the hospital side of it, and concluded that there's something there that warrants a closer look. So I referred her for a formal assessment, and she was diagnosed with opioid use disorder. She was referred for specialty treatment on the mainland. We always recommend that our participants who are going to residential treatment be among peers. Research has shown that treatment is much more successful when you're in a group of people that you feel like can understand you. Hawaii doesn't really have a program like that, but there are several on the mainland that are really good that specialize in the treatment of healthcare professionals. So we send them to one of those facilities. So when she gets there to the residential treatment center on the mainland, she's detoxed and she's placed in a cohort with other healthcare workers. She spends 60 days on the inpatient residential program, and then she's stepped down to an IOP, intensive outpatient program, for 30 days. Her husband was able to come and visit her during a family support weekend, and at one point she was allowed to visit home in Hawaii for a few days. So when she's discharged, the treatment center recommends that she start a monitoring agreement with us, engage with psychiatric treatment and an extended IOP. She was started on intramuscular naltrexone while she was in treatment, and she's advised to remain off of work for the period of 1 month. So these are her initial requirements. So we ask her to do 4 random drug screens per month, 7 12-step meetings per week, and obtain a sponsor. She's to meet with me regularly and continue her IOP program, to maintain a relationship with a mental health provider that has addiction credentials, and to remain off work until cleared. And these are pretty intense requirements at the beginning. Over time, as people do well and get further on in their recovery, we lessen the requirements. So over time, there will be fewer drug screens, fewer meetings required over time as they get better. So after a month, she returned to work for part-time at first, and then gradually back to her full-time work after about 3 months. Her worksite monitor was the chief of her department, and he reported that she was doing really well, no indication of substance use. The pharmacy records show appropriate use, no signs of inappropriate wastage, and we're getting positive reports from her treatment providers. So she finally was successfully discharged from the IOP program, and naltrexone was discontinued. She's doing well. About a year and a half into her contract, though, she had a blip. So she forgot to check in with the lab, and she missed a scheduled urine test. So we take this pretty seriously. A missed test is considered a positive test. So we ordered her immediately to stop practicing, and we referred her to be reevaluated for her recovery status. We let her employer and her worksite know, and we increased her drug screens back to 4 times a month. So this happens sometimes, right? We have instances where there's a setback or other types of non-compliance. So that might be drug testing irregularities like testing positive or missing a test or evidence of adulterated specimens. Maybe they're not attending the required number of meetings or coming to meet with me as required. Maybe they're not really communicating with their worksite monitor, or just any refusal to follow our recommendations. Maybe an example of non-compliance with us. So when that happens, we have several potential responses. We may order them to stop practicing temporarily till we can get a handle on what's going on. We may reevaluate them to see kind of what their recovery status is. As we did with Dr. A, we may change the monitoring requirements, increase the frequency of the drug screens or the meetings, notify the third-party organizations, their employer, or the organization that referred them to us, and we may even extend the monitoring agreement if necessary. So back to Dr. A, she went back to be reevaluated, and given that she has had such a strong record of monitoring, there's no indication that this was an actual relapse. So she was allowed to return to work. We did continue the increased drug screening, and we also started doing quarterly nail collections as an additional sort of test. She's now in year 4 and doing great, has no further compliance issues, and will be finishing up her contract with us for the next year. So monitoring is hard. It's very tough on the participants that are referred to us. It's expensive, it's time consuming, it can be really anxiety provoking for our participants. It can be embarrassing. There's a lot of stigma that goes along with this. People may be worried that they're gonna lose their license, this is gonna ruin their career. So this is really stressful, and we acknowledge that. But we also know that this really works. This was a study done a few years ago looking at physicians' health programs across 16 different states. They looked at over 900 physicians, and 78% of them were licensed and working at the end of their 5-year monitoring period. So yes, this is really hard, but this is one of the most successful and effective substance use treatment models that we have. So this is sort of the secret necessary components for this to work, right? These are the things that make it successful. Zero tolerance for alcohol or other substances of abuse, a very thorough, formal and individualized treatment, prolonged and frequent testing. So that's why the long 5-year contracts, effective use of leverage, and swift and certain meaningful consequences for any non-compliance. And we really try to encourage a lifelong recovery, not just for the time that they're with us, but for the rest of their life. It's rooted in 12-step fellowship. So there are benefits to being a part of our program. This is, I believe, a different study looking at PHPs from several different states. And most people involved in a PHP said that they appreciated that PHP helped them to maintain their sobriety and also maintain their job. When these kind of things come up, people are often worried about their job status, but being a part of a PHP may actually help them be able to keep their job, as well as improving their own personal life, their relationships, and their spiritual life. That same study, 78% of participants were either satisfied or very satisfied with the PHP. And all those that were reporting any kind of dissatisfaction were currently in their monitoring contract or had their contracts extended. 93% of people would recommend PHP involvement to a colleague. And again, those who would not recommend it were still under contract. We do have another program that we offer, supportive case management. This is very different from our monitoring agreements. This is more of a preventive sort of program. Burnout is very real. 400 physicians commit suicide every year. Compared to the general population, the suicide rate for male physicians is 40% higher, and for women, it's 130% higher. We know that 10% of healthcare workers have a substance use disorder. Over 50% of us at any given time have some symptoms of burnout. And if these things aren't addressed, they could lead to really serious problems. Inappropriate behavior at the workplace, job dissatisfaction, substance use, early withdrawal from practice, and in the extreme cases, suicide. It's also very expensive to the community to have a reduced number of healthcare providers. It can also be very expensive to employers. It can cost almost up to $1 million to replace a single physician that is lost. So we have these barriers to standard monitoring, all these things that make monitoring really hard and stressful. So the supportive case management program strives to eliminate those barriers. It's confidential, it's completely voluntary, it's non-disciplinary, and it's completely free. So our supportive case management program, we prefer self-referrals, but we'll also accept them from a partner organization. Some reason someone might come to us for the supportive case management might be signs and symptoms of depression or burnout, work-life imbalance concerns, or behavioral concerns. Those with any kind of severe mental or medical disorders, substance use, or any sort of legal involvement would not be appropriate for the case management program. This is strictly preventive to avoid it getting to the point where they need to be a part of the monitoring. So this process is much less involved. It's they would meet with me. I would do sort of a informal evaluation, and then we would talk about options. Maybe somebody just needs to sort of chat with me every once in a while. I don't do the therapy so much, but we can do some coaching, some guidance, just to help sort of talk through some of these issues. We can also make referrals to outside services and organizations if needed, and talk about resources where they can find help. And then we also talk about a maintenance plan. If we're able to get them through that acute sort of episode, how can we build these healthy practices lifelong? So we thank you for having us. We are proud of our roots with the HMA, and we hope we can continue to be resources for HMA physicians.
Thank you very much, Drs. Young and Gough. Very helpful to have the overview and to start with such a personal story. I think that's very moving. Thank you, Dr. Young, for sharing that. So a number of questions have already come in, so kind of jump around a little bit if that's okay. Thank you. First off, one of the questions that came is, how is the program paid for? I noticed you mentioned that the supportive case management alternative, that one's free, but the other one must be very costly.
Yeah, good question. So our funding comes primarily from agreements with partner organizations like hospitals and other agencies. We have agreements with most of the major hospitals in Hawaii. So that kind of helps us to sustain ourselves. There is also monitoring fees that the participants pay. And part of that is to sustain our operations. And also part of it is to help them have a stake in their treatment, to literally invest in themselves and in this process. I don't know if you want to talk any more about the funding piece.
Well, the funding is we actually have individual donors donated to us, other physicians. But the primary funding is from the major healthcare organizations in the state. And they're listed on our website, as well as one of the major insurance companies in the state. And we're constantly looking for new sources of funding, as most 501c3s are. And we've been really, really grateful for all the support of the organizations who have funded us for years. It's just been a huge thing for the people, the doctors in Hawaii, and of course all the other licensed healthcare professionals.
So the other program, the supportive case management program, how long has that been in place?
I can only speak to, since I've only been here a few months, my understanding is that it's relatively new. This was sort of the brainchild of my predecessor. So it is a relatively new program.
And then kind of curious, what is the breakdown of people that participate in your main program versus those that are in the supportive case management program? What would you say the percentage of clientele?
So right now, the vast majority are in the monitoring program. Fortunately, there are other resources besides us for support for doctors, but we are the only monitoring. So I think that kind of helps explain why there's that sort of imbalance. But right now, it's mostly monitoring that we have.
And you sort of touched on this before. Do you all provide the treatment and therapy yourself, or is most of it outsourced? Kind of touched on that a bit.
Yeah, so I don't do any of the treatment myself or the evaluations. We feel like that would be a conflict of interest. We do have organizations and treatment providers that we work with frequently, so we can make those referrals. We usually, like to try to give people several options in, choosing their care. But we like to stay, pretty objective in maintaining the monitoring.
So are there now in Hawaii more monitoring support programs than there used to be, or do you still have to usually send people to the mainland?
For residential treatment, there's really nothing in Hawaii for healthcare providers. So there are several on the mainland that we work with quite frequently. But nothing in Hawaii just as of yet.
I think it's pretty clear that most physicians are very concerned about their anonymity, about their ability to not have everyone know what they're going through. And just speaking from a personal situation, way back in 1986, the only places my husband was, and I were comfortable having him go to were places that had physician-only programs or professional programs. And we really only wanted to go to programs that were run by a physician in recovery. And that is who really understands. And of course, I think the vast majority of physicians who do require a PHP for monitoring after treatment, I would say they all feel this way. They just want to go somewhere where they feel safe, where they feel someone who has been through what they've gone through would understand. And there's some very, very skilled facilities on the mainland that do this for not just physicians, but pilots, lawyers, people whose licenses are on the line. And I think that in my experience, the docs who were treated early before they basically got into trouble at work, which was my husband, he was treated very early. When he came back, there was disbelief from a lot of colleagues. They're like, really? You had to go do what? And, I was really proud of him because, he was open, and his sharing helped a number of other folks later on who only felt safe talking to him. And not just physicians, these are people in the community. There was a visiting relative, a very prominent national politician, who would only see my husband in the emergency. This guy relapsed, and so my husband had to go to work. I mean, he might have been scheduled, but this guy would only see him. And so that's how this kind of thing works. And the fact that now we have a formal physician's health program, we're just a lot more out there publicity-wise with the physicians in the state. I think it's really, really helpful. And having the support of the organized medicine has been huge for us here. So Angela, too, has been very active with, we've been talking to the residency program for our medical school. We are actually talking to the HRP, Hawaii Residency Program, at the end of this month. And there are, I believe, over 200 residents in the state. We just want to publicize who we are, what we do. This is pretty much state of the art for caring for healthcare providers who need mental health, substance use disorder treatment in this country. There are actually 47 PHPs in the United States, not including the District of Columbia. There are actually 3 states, surprisingly, that do not have PHP. One of them used to, but we've heard that they're working very hard in these states to reestablish these programs.
You know, next week we're going to be at the residency programs at Queens. We're going to have a table to recruit members to HMA. But if there's material that we can share on your program, please, we'd be happy to bring it with us. Because I think any opportunity to get this kind of information out there to help mitigate the stigma, but also just educate physicians and other healthcare professionals about the opportunities, supports that are out there, so absolutely critical. Especially with the information that you shared, suicidal, ideations, but just we want to touch people before it gets to a crisis point. So happy to do that. I'm curious, your husband and what you went through over many years ago. Do you see that the stigma has been reduced much, or is it still kind of a challenge?
It is still a challenge. It is way, way better, obviously. I think it's night and day. It really is night and day compared to when I was a medical student, per se. And I think it is the courageous sharing of physicians in recovery that, they've dropped their anonymity and they've just gone public. And there's actually 2 very interesting videos on our website. One was had Dr. Carrie Cunningham, who was she's a surgeon at Harvard, and she tells her story. It's right there. It does take an hour to watch, but it is riveting. And then the second video is of her sharing how her state's PHP helped her with the past president of the Federation of State Physician Health Programs, Dr. Christopher Bundy. And so it's very, very interesting. And I think that if HMA members have the time to check out these videos, it is well worth it. Angela and I have gone to a number of, there's actually a couple hospitals in the state that do not have a formal contractual relationship with us that we have gone to meet. And some of their members of their executive committee have actually watched these videos, and they were just blown away because it is very courageous. But the fact is, most of the major treatment centers in this country were founded by physicians in recovery. And it's been great for not just the doctors in our country, but the patients, right? Because it's just a lot of people.
Well, there's nothing more powerful than peers supporting peers, especially those that are going through recovery themselves and who have the courage, as you so well articulated, to tell their story. It's not easy to do, but the power and the influence that it can have to save lives and not just save careers, but for help patients. I know the Federation of State Health Programs spoke very highly of Hawaii's program when they were here when we had our American Medical Association interim meeting a couple of years ago. So this program is so widely respected, even if we don't talk about it that much in many ways. But I think it's a wonderful way that you're getting the word out more and more. Another question that popped up is, do you ever report doctors in your program to the medical board?
We really try not to. There are cases where the medical board will refer someone to us. And in those cases, of course, we would communicate to the referral source. But generally, we really try not to. We really try to maintain that confidentiality and that privacy. As long as someone is, in good standing, in compliance, following all our recommendations, there's no reason for us to let the medical board know about their involvement with our program. We feel like that privacy is really important to, allowing physicians to feel comfortable working with us, because that can be really intimidating.
Sure. Another one of our participants asked, if a physician from the mainland wants to move to Hawaii to practice and applies for a medical license from the state of Hawaii and has a record of drug or alcohol abuse in the past, is that physician required to be automatically monitored by the program or a separate program?
It's certainly not automatic. We do get referrals like this sometimes. This is often where we get referrals from the state medical board. Someone out of state is moving here. They are, wanting to get their Hawaii license. They disclose that they have this history. So that would be a case where the Hawaii medical board would refer someone to us to see if there's something there. And so that's, I would meet with them, and then if necessary, refer them for an evaluation, and that evaluation would kind of let us know, is this something that we need to keep an eye on or not? So it's certainly not an automatic thing.
We often read about attorneys getting disbarred, dentists committing suicide. Do you all deal with those professions?
We do. We not attorneys, but dentists, yes. So any healthcare provider, so dentists, veterinarians, psychologists, yes.
Now, physician health programs like ulu Lapa are a little different, I think, from physician wellness programs that also exist in places like Virginia has a safe haven program. It seems like PHPs deal more with impairment, wellness programs focus more on prevention and joy. Is your supportive case management program more like a kind of wellness program, or do you draw a sharper distinction between your PHP program and these other wellness programs like the Dr. Warner Foundation programs?
Yeah, I would say that the supportive case management is more like a wellness program. There's no standard for what a physician wellness program means, really. So that can mean sort of whatever the organization wants it to mean. But there is a very clear standard for what a PHP is, and that's defined by the Federation of State Physicians Health Committees. So not every PHP has a supportive case management program. We felt like that was a need, but it is very different, the monitoring piece versus the supportive, wellness sort of encouraging.
Maybe you could discuss a little bit more about your supportive case management program and what kind of elements make that up.
So it's very individualized. It kind of depends on what the person is coming to us for. This could be, somebody's really burnt out, or maybe they're having, like their boss, they're having some conflict. Maybe they're at a junction in their career and they don't really know which way to go. And they just need somebody to sort of chat with. So it could be as simple as just meeting with me a few times, or it may be something more serious where then I would put them in contact with other treatment providers and referral sources.
Do you do any special presentations on the supportive case management program, or anything that could help maybe address some of the prevention issues?
We do. We kind of make the rounds to the different hospitals and present to the medical executive committees. We're also, as Geri said, we're going to present to the residents next week, I guess, telling them a little bit about us and letting them know that the service is available. And so we do try to, get the word out.
Mm-hmm.
That that's
Another question that came up is, how does monitoring for behavioral issues differ from monitoring for substance use disorder issues?
Yeah, so behavioral issues could be anger issues, inappropriate behavior with colleagues, boundary violations, those type of things. In those situations where there's not a clear, substance use problem, we may or may not do, the urine, the drug tests, right? Otherwise, it's fairly similar. There are, again, programs on the mainland that really specialize in this, and it's very similar to a substance use recovery. Often when there are these behavioral issues, there's an underlying mental health issue, right? And so part of the treatment is teasing that out and making sure they're getting treatment for that need.
So Hawaii's program since you're part of the larger federation, how does it differ from some of the programs that you find in other states?
So the structure varies quite a bit from one state to another. Many state PHPs have an affiliation with the medical board. Some of them have an affiliation with the medical society. Ours is completely independent. Most of them only serve physicians or nurses, whereas we serve all healthcare providers. So there's lots of different ways it can be structured, but the sort of main ingredients of what the monitoring entails is all pretty much the same.
So what are the strengths and the weaknesses or challenges that the Hawaii program faces in comparison to other state programs?
I think a benefit of us being independent is the confidentiality. You know, it may be a barrier for somebody to come to us if they feel like we're affiliated with the medical board. That's understandable. That comes with, though, the other side of that is you don't get the funding, right, from those parent organizations that the other state medical boards have.
Now, I noticed from some of my national meetings that some states like Virginia, South Dakota, and Indiana have passed laws to provide safe space for physicians and other healthcare professionals so that they can seek and obtain confidential care that would not negatively impact their careers. And oftentimes the language I think that's introduced is around career fatigue and wellness versus burnout. Do you have any comments on some of the things that maybe Hawaii should look at doing, or do we have sufficient supports in our law and resources to provide the kind of care that our physicians and other healthcare professionals need?
To my knowledge, Hawaii doesn't have any statutes that apply to a physician's health program, and many states do. And those statutes often offer protection, for example, for the records that can't be subpoenaed under any circumstances. And so that kind of, coded protection is really important, and one of our ultimate goals is to get that sort of statute in Hawaii, just like in many other states. Another thing that we're looking at is the language on the medical license renewal forms and application forms. There's a question on there about, have you in the last 5 years had an issue with a substance use disorder? And in many states, that language is being reworked to offer, again, some more protection from those that are in recovery.
So like what would be the preferred language, just as an example?
Yeah, so the preferred language is something along the lines of, are you currently suffering from any condition that would impair your ability to practice? And if you're involved with a PHP, you may answer no. That's kind of the second piece of that.
No, I think this is an issue that's come up, and I know our current president for the HMA, Dr. Elizabeth Ignacio, based in Maui, I know one of her foci is on physician wellness. So perhaps maybe in the next legislative session, there might be an opportunity to work together on some of these issues. Because I do think there is sympathy and support in the state legislature. And I think it's also helpful that we have a physician governor right now, too, who knows very much what physicians and other healthcare professionals are facing. So it could be an opportune time to educate and perhaps bring forward some legislation to support our physicians better. So as you look at the landscape right now, the needs of physicians and the healthcare professionals, how do you think things are changing or shifting? Have they shifted in the past, say, 5 years? And where are they going in the future?
I think there has been a shift. I think within the last 5 years, we've seen more discussion around physician wellness. We're seeing these, wellness programs sort of pop up. And so I think that's what we're seeing, is increased awareness. And then the next step is, okay, what do we do about it, right? So that's, I think, the next kind of horizon is, where do we go with this? Now that we know that there's this problem, how can we address it?
Now, Hawaii oftentimes is a few years behind whatever is going on the continent. So wellness programs, quite frankly, have not gotten as much attention here in Hawaii, it seems to me, as they have on the mainland. What would you like to see in terms of physician wellness programs and preventive programs here in Hawaii next few years?
I mean, I think ultimately it has to be a culture change, right? Because, sometimes these wellness programs, it's like, well, we're going to have a pizza party, right? And that's not really what you need, right? So I think it starts with, educating the younger generations, the residents, the medical students, because sometimes medicine is sort of a toxic kind of culture. Like we're taught that we're supposed to be superheroes, right? We're not supposed to get sick. We're not supposed to have needs. We're just supposed to care for other people. We're supposed to always be on. So I think changing that perspective is going to be really key to just changing the culture.
Now, related to that, and Dr. Young, you and I were talking a bit about this, Dr. Gough as well, prior to this session beginning, but how there's been such huge shifts in organized medicine and practice of medicine. How has that affected physician wellness and some of the addiction issues that physicians and other healthcare professionals are facing?
Well, I was telling you guys that the biggest change in my professional career was the advent of the electronic medical records. I think one of the unintended consequences of electronic medical records is the increased isolation of the physician, because they are so busy typing or charting that, so in my career, okay, I started on Kauai in 1981. I retired last year, so that's 42 years. We went, my employer was Hawaii Pacific Health. We bought Epic in 2003 for a huge sum of money. In pediatrics, we went what was called Live in 2006. And whereas before, I used to chart outside and talk to my partners around kind of a square-shaped area. We talk about cases, or I just ask their opinion, and then I'd scribble something on my medical records, and that was it. But now the doctors are in their exam rooms with the patients, they're charting. I don't know if you've noticed when you've seen your doctor, sometimes they're turned away from you and they're typing. And so what these guys have to do, because they're trying to get all their work done, is a lot of them will type during the morning session. They'll chart a little bit. They'll finalize their charts at lunchtime, and then they'll see their afternoon patients, and then they'll chart a little bit, but they have to go home to take care of their families. And then they're charting at 9 or 10 or 11 o'clock at night. And what we could see because this is a huge change in medicine. And I think it sounds weird if you're a non-physician or a non-clinician, but this is, I think they call it pajama time charting. And actually, Epic allows you to see how many hours during the day someone's charting. And if some guy, there were some clinicians, it's pretty rare, but they're charting because you can see it 20 hours a day. That's pretty horrible. And that's not even thinking about depression or marital problems or anxiety or perhaps even substance use. That it doesn't even cover that. It's just the work. And so the clinicians have to get really good with the EMR. Either they're going to have to take typing lessons, or they're going to figure out a way to deal with this, because this is a huge problem in organized medicine, is the EMR, and how good the clinician is at charting. Is it accurate? Are they able to do this as well as doing their personal life? And I think probably the American public has no idea that this has happened in organized medicine over the past 20 years.
And what you're saying is that it has tremendous impact on the mental health and the joy of practicing medicine. Now, this would bear its own conversation
Right.
at HMA. But I mean, of course, the key question is, what are the solution strategies? Not to be
What are
answered
the
now.
strategies? It's a whole nother hour.
Right, exactly.
Or more.
Right.
Yeah.
Yeah.
Because I know that AI has been looked at. There's been a lot of different things being looked at. And the hallucination piece of AI is not helpful. Where the thing makes up stuff. So yeah, I could just go on and on.
Another topic, but the point is, this kind of modernization has a direct impact on physicians, on the healthcare professions, but especially physicians, and feeds.
Right. And the whole isolation.
Yeah.
Because they're so busy. Okay, they're seeing their patients, and then they're charting, and then they're seeing their patients, and then they don't even get to see their colleagues.
Sense of community and collaboration, camaraderie.
Which is why organizations like the HMA are so important, because it's the socialization. It's so that they can see each other and ask small questions, because they're all sharing the same, irritations with their EMR or whatever. And I think, to me, that's one of the biggest challenges of EMR is the isolation, the increased isolation of the physician.
Thank you. A couple more questions have come in. One of them is, if an institution, for example, a hospital wants to contract with ulu Lapa to be a resource for physician health issues, is there an annual fee, or is it a voluntary contribution? Is it something about asking a medical officer for a hospital? Someone like that is asking this question.
The major hospitals in the state have contractual relationships with us, and they have for years. That's how we are able to support ourselves, because we're very small. But the companies have been very supportive, and I'm happy to take that offline if they're asking me if they could talk to me. I'm
sure.
If they identify the organization, I can help them.
So we'll make sure we put your contact information up on the website.
Absolutely.
And of course, we already link to your organization because of the history and the important service that you provide to our physicians. But we'll make sure that information is out there. Another attendee wrote the following: "Thank you for this great presentation. I remember the old days of HMA's Physicians Committee and the hard work of Dr. Gerald McKenna. Dr. Young probably knew from the past."
Absolutely.
In fact, you mentioned Dr. McKenna.
Yes, he's a very good friend, and a huge loss. Angela and I both knew him very well.
Another attendee commented, "Dr. Young is spot on with the EMR, adding to the stress of the practice of medicine." You gained a few fans, I dare say.
Oh.
Well, we're getting kind of close to the end of our time here, and I want to give a few minutes for each of you to make whatever closing comments you wish to make. So we can maybe start with Dr. Gough, please.
Yeah, well, thank you for having us. We really appreciate the chance to, tell your members about our organization and what services we provide. Ultimately, we want healthy physicians because that makes for healthy patients.
Yes, thank you so much for inviting us here. It's just been a lot of fun, and we're happy to take any other questions that HMA membership has, and we're happy to take it offline.
Thank you very much. And we really appreciate you both giving of your time today. And we're also grateful that you both are members of HMA as well. And HMA will do whatever it can to get the word out and to support this wonderful program, which has touched the lives of so many folks. So thank you very much. As we come to a close this evening, I want to thank everyone for joining us for this edition of Conversations at HMA. Again, mahalo to both Dr. Geri Young and Dr. Angela Gough, and all of you for participating this evening. We know you have your choice of activities, so we thank you for spending some of your time with us. This program and the attachments will be made available to HMA members and the general public by early next week. It will be posted on our webpage on the HMA website. And again, mahalo and have a great